All right, we'll get started then. Good afternoon, everyone. Welcome to Trust for America's Health's Age-Friendly Public Health Systems April training. We're so happy that you're here today to join us to build your knowledge and expertise in public health strategies that can support older adult health and well-being. My name is Megan Wolf, and I'm joined today by three colleagues, actually. So my colleague, my partner in crime, Dr. Karan Phillips, who's also on the Age-Friendly Public Health System team. We're also joined today by our colleague, Matt McKillip, who will be our presenter, and our intern, Katie Vinson. So the good TIFA team here today. And I just want to acknowledge the support and partnership with our funder, the John A. Hartford Foundation. Without their partnership, we would not be able to do any of this amazing work. So thank you to our partners at Hartford. Next slide, please. Okay, great. Thank you. So as I said, please keep your devices muted during presentation so we can avoid any background noise. But we do invite you to put questions in the chat. We will have plenty of time for some discussion after the formal presentation today. Next slide, please. So all of our AFPHS trainings are recorded, and the slide deck is shared with everyone who has registered for the trainings afterward. But if you're using an AI note-taking tool, please let us know by commenting in the chat before our speaker begins. In addition, you must be present in the training with the AI note-taking tool. Any notes generated from an AI tool may only be used for personal use. All right, next slide, please. So one more piece of logistics. So your feedback is really helpful to us. It's very valuable as we plan these sessions. So we would ask that after the presentation, this survey will pop up if you'll just take a couple of moments to complete it. It's completely anonymous, and we really appreciate your insights that are also shared with our evaluation partner, the New York Academy of Medicine. So appreciate your time there. And next slide. So most of you, I think, already know who we are, TIFA, Trust for America's Health. We are a public health policy research and advocacy organization dedicated to optimal health for every person and individual. We produce a number of different reports every year, and today we're going to focus on one of those reports, our 2025 Ready or Not report. We also have developed several briefs related to our healthy aging portfolio, including some featured on that are focused on housing, on rural healthy aging, and aligning the 10 essential public health services with our age-friendly public health system 6Cs framework. Our next brief coming out will be on public health roles in supporting family caregivers. So look for that from us in the next couple of months. All right, next slide, please. So as I mentioned, today's training is on our 2025 Ready or Not report. This report measures states' preparedness to respond to a spectrum of health emergencies and to provide ongoing public health services. And the measure is based on a set of 9 key indicators that you're going to be hearing quite a bit more about today. The report also gives federal and state policymakers actionable data to improve their emergency readiness. So without any more words from me, I'm going to introduce our speaker for today, our wonderful colleague, Matt McKillip, who is a senior health policy researcher and analyst at TIFA. Matt, I will turn it over to you.
All right. Thank you so much, Megan and Karan, for having me. I'm really delighted to be here to speak about our Ready or Not report, which we just released a couple weeks ago, and try to zoom in especially on some of the data we present and the recommendations we include that are, I think, particularly pertinent for older adults. So I will go ahead and get started. So just a little bit of background, and I'll provide a bit more too on the next couple slides. But Ready or Not is a report that we release, we at TIFA release annually. It is meant to do a couple things. One is to try to measure, in a sense, the level of public health emergency preparedness at the state level by tracking 10 key indicators that we think are very representative of a whole host of preparedness capabilities, as well as try to try to focus on indicators that are particularly actionable for policymakers. We also include a set of policy recommendations for policymakers at the federal, state, and local level. And often as well, we'll include a year in review in case this is an issue that folks track, but maybe not on a daily basis or weekly basis. We try to kind of provide a nice summary of major developments over the past year that can be a useful resource. And in recent years, too, we have included special features that really home in on particularly timely topics of significance in the latest year. And I'll be able to speak a bit more about that. Next slide, please. So just a little bit of background context on our Ready or Not report. We at TIFA have been releasing this report actually for more than 2 decades. The report began shortly after the terrorist attacks of 9/11, and particularly in relation to some of the concerns regarding bioterrorism at the time. And it was an effort in 2003 to begin looking at a kind of examining a surge of federal policy actions that had taken place to strengthen the country's readiness for bioterrorism, and also to look at the way that funding was being allocated at the time and employed, and really try to kind of assess the effectiveness of those uses and so forth. Over the last couple decades, we've continued to release this as a part of an annual series, and we've broadened the scope of the report beyond just bioterrorism to really try to take more of an all hazards perspective, trying to think of the whole range of potential public health emergencies that we could face. So, of course, one top of mind for everyone still, I think, is the COVID-19 pandemic. So thinking through the necessary capabilities and preparedness steps that can be employed to be ready for infectious disease outbreaks and pandemics, but not just that. We try to think about environmental and weather related hazards and other types of hazards that that public health departments and partners can try to be ready for. We know it's always best to try to invest in those capabilities ahead of time and to have planning ahead of time so that when emergencies strike, which we know they always will, we just don't know exactly when or what the exact dimensions of them will be, that we can be as ready as we can be at all levels of government. Next slide, please. So this is the cover of our most recent report, which we released in late March. And we, in this report, actually introduce a new indicator, which I'll speak about, and include a special feature actually on the increasingly concerning and growing threat of H5N1 bird flu. And so I'll speak a bit about that, and I think its relevance for older residents in the US. Next slide, please. I mentioned before that as part of the report, we try to assess state level preparedness by looking at a set of key indicators. These are those indicators. In general, we're looking for indicators that have highly credible data sources, that are updated on a regular basis, where there's relatively clear and agreed upon kind of scientific connection and validity for, as I said, a wide range of emergencies as well as preparedness capabilities, and try to a degree, as best we can with 10 indicators, try to kind of cover the waterfront in that way by looking for measures that are important of themselves, but often can kind of serve as proxies for other capabilities. And so we try to keep these relatively consistent over time so that we are not moving the goalposts too frequently, but we do update indicators when we feel like we can make improvements to the set. And we actually did introduce a new indicator this year. So just real quickly, I'll kind of touch on a few of these. Just one, a couple of note is an indicator that looks at participation in the Nurse Licensure Compact. This is an agreement that states can join to help nurses travel across state boundaries under essentially a shared license protocol, and to really streamline that process so that in the event of a healthcare surge, states can really staff up quickly and avoid kind of cumbersome processes and delays that often slowed that process down in the past. And, we saw certainly during the most acute times of the pandemic that there were kind of rolling surges where hospitals in different regions were reaching, near the brink of being overwhelmed. And so this is we think an important step that states can take to try to ready themselves for that so that they can surge up staff quickly and efficiently. We look at a couple different types of accreditation that speak to kind of adherence to a set of, best practices. It certainly speaks to, I think, a certain amount of rigor and capability among public health departments and emergency response departments. And so we think those are important measures. We look at state level public health funding, and this is actually data that we collect and generate on our own. So this is a primary data source. Really, it speaks to public health infrastructure, resource, and sort of capabilities overall, as we know that strong public health departments are inherently more prepared to be able to deal not just with day-to-day needs and services, but for emergencies. We look at water security and specifically at community water systems and the level of adherence to health-based standards. We look at usage of paid time off, as we know that this is an important lever and really benefit that can help not just give people time to either address ailments that they might be having or that of family members, and if they're serving as caregivers, but also to help break chains of infection during outbreaks of infectious disease and so forth. We look at rates of flu vaccination, and I'll touch on this a bit more shortly. But this is important in and of itself. This was a particularly bad flu year that we're coming out of, and so we know the importance of flu vaccination, but we also think that this speaks to the level of preparedness for state health departments to ramp up a vaccination campaign for other vaccines as well. So we think that this really kind of gives insight into that. We look at patient safety and the level of quality controls and so forth in acute care hospitals in a state. We look at the extent of documented planning for public health labs to be able to surge up in the case of an emergency. And finally, the new indicator we introduced this year looks at avoidable mortality rates, specifically before the age of 75. And this, I'll unpack this a bit in a moment, but this is really trying to better understand the rate of deaths in a state that are tied to causes that could either be prevented or treated and avoided in that way. Next slide, please. With our analysis of all of these indicators, we then kind of create a composite measure for states and place every state plus the District of Columbia in one of three tiers: high, middle, or low. And the way that we kind of think of and frame these tierings is that while every state absolutely has room for improvement, and certainly the country as a whole, states that we place in the high tier generally show strong performance across most or all of our indicators, whereas states that are in the lower tier usually tend to show that there's really greater room for improvement among the indicators that we're looking at. In several cases, they are below um, national averages, or might not have become accredited by either of the bodies we look at, and so forth. And so it's really just to try to give policymakers at the state level, as well as public health practitioners and so forth, just a general sense of kind of where they're stacking up, at least among this indicator set, relative to neighbors, relative to peer states, and maybe give them a bit of a blueprint for improvement. Next slide, please. I mentioned that one of the indicators we look at is rates of flu vaccination, and this is important because it's one of the most significant measures that we can take to protect individuals from seasonal flu, as well as it is, I think, provides some insights about the likelihood of success for other vaccination campaigns as well, whether it's for a novel vaccine or for a vaccine for a novel threat, such as the introduction of the COVID-19 vaccines or new RSV vaccines or others. And importantly, this is actually one that we can disaggregate by age group. And so I thought it might be useful just to take a moment and look at this. And what we see um, consistently, and there's actually, I think, a couple patterns in recent years. One is um, a steady decline in overall vaccination levels coming out of 2021. Really, we saw a ramp up um, during 2020 and 2021. I think as there was sort of general increased awareness and sensitivity to the risks involved with infectious disease and potentially co-occurrence of having seasonal flu as well as COVID-19. But really, in the last few years, we've seen a steady tapering off, which is concerning. And just to kind of give a benchmark, the national goal is to have a rate of 70% for the country, and we are well below that. We've been hovering around 50% for the past few years, and are actually coming in below 50% in the most recent season that we have data for. That said, I think one important bright spot is that we do see that for individuals who are 65 and older, there's consistently higher rates of vaccination. And I think this is important because we know that this is a population that can often experience more severe illness and increased likelihood of hospitalization and so forth from seasonal flu. And so it's really important that age group continues to receive vaccines at high levels, and not just I would say that we sort of get the message out in sort of an individual treatment way, but that we have systems in place to make sure that it's easy and that we're increasing access and so forth, and that it's affordable for this age group in particular to continue to receive vaccination at that high level. Next slide, please. I mentioned we introduced a new indicator this year as part of our set that looks at avoidable mortality, and specifically looking at deaths before the age of 75 that data would suggest could potentially be prevented, and really trying to look at deaths that could be prevented either through public health measures, through vaccinations, improving the safety of environments, increasing awareness and adherence to healthy behaviors, or from treatable causes. And so really these are deaths, thinking, for example, of from certain cancers that can be detected early, that we think could be treatable and avoided through access to high quality, timely healthcare. Next slide, please. And so as you can see here, this is actually an image that comes from the Commonwealth Fund, and that is our data source for this indicator. There's significant state-by-state variation across the country in terms of rates of avoidable mortality. So you can see all the way there at the left, states like Massachusetts, Minnesota, Hawaii, and so forth have relatively low rates that are well below the national average. And this really speaks to, I think, you know, relatively well-resourced public health systems that can offer a broad range of services and public health infrastructure that really allows them to be effective in their work and to have the resources they need to successfully increase protective measures and to have successful information awareness campaigns and so forth that really can try to head off some of those preventable deaths or treatable deaths. And likewise, it speaks to increased insurance rates, greater access to high quality healthcare services from primary care physicians, as well as perhaps through hospitalization. On the flip side, we see states like Mississippi, West Virginia, and Oklahoma with much higher rates. And you know, this sort of speaks to the alternative of all of those. This is indicative of, I think, of public health systems that are more strained, more under-resourced. It's difficult, more difficult in these areas to try to reach residents and really to provide the types of comprehensive services that those departments are aiming to provide. Similarly, it speaks to relatively less access to high quality healthcare. In terms of the relevance of this for public health emergency preparedness, you know, what we know is that while public health emergencies can and will affect all residents, all states, all localities at one time or another, the impacts of those will be felt unevenly. And the capabilities to withstand and having the wherewithal to manage them is uneven. And so really we know that certain places will enter a public health emergency at an advantage and others will be disadvantaged. And so places that in non-emergent times can keep these rates of avoidable mortality low, which speaks not just to the capabilities of their public health and healthcare systems, but also the circumstances related to other social determinants of health, whether it's the quality and affordability of housing, levels of food security, and so forth, will really well position certain places to be able to manage through a crisis quickly and to recover quickly, whereas other places are going to be more disadvantaged. And so that was our rationale for including this year. Next slide, please. The other way that we track this data in our report, besides disaggregating by state, is that we also look at disaggregation by race and ethnicity. And specifically, we look at the level of disparity between races or ethnicities with the highest level of a rate of avoidable mortality in a state compared to the lowest level. And really trying to essentially, I think, try to reflect, I would say, the level of health equity in a state, or alternatively, the extent of disparity that might be occurring. And so this slide, I think, is useful for just really demonstrating that certain populations, you know, have consistently much higher levels of avoidable rates of avoidable mortality in the states, whereas others are much lower. And so, you know, for example, we consistently see that American Indian and Alaska Native populations, as well as Black residents in states, have relatively higher rates, whereas Asian Americans and white Americans and so forth often will have much lower rates. And so that's, I think, an important metric to keep an eye on, not just at overall levels, but at the level of disparities that can sometimes exist between race and ethnicity. Next slide, please. I mentioned that we have, as a practice in recent years, been including special features in our report that try to focus a little bit more specifically on timely topics. Last year, for example, we included a special feature on extreme heat and the risks surrounding heat, especially for certain populations, including older adults. And so I would definitely recommend that for anybody who's interested. This year, knowing the growing threat over the past year, especially related to H5N1 bird flu, and some of the, I would say, echoes of the challenges and experiences of the early response to the COVID-19 pandemic, we really wanted to kind of dive into this and lay out some of the context for what we've seen over the last couple of years, some of the risks. Right now, the risk to the general population is low, according to the CDC, but it's significantly higher for some folks, including in certain industries, such as farm workers and others who are working within agriculture. But really, I think one of the important lessons that would apply to everybody is we really want to better test and track the incidence of H5N1 and make sure that we have the testing capabilities that we need. And we've seen evidence that we haven't been successfully testing enough in certain cases to really understand the levels of transmission. But ultimately, we really want to keep transmission rates low because every time there are these transmissions, it allows the virus to potentially be able to mutate in a way that will make person-to-person transmission easier. Whereas right now, we're not really seeing that a great deal, but all of that is going to be dependent in part on the effectiveness that we can have for cross-sector collaboration between public health departments and agricultural departments and so forth, as well as across government, non-governmental sectors and industry, and really working together. And what in the feature and has been framed by CDC and others as kind of a One Health approach, understanding that health risks to animals and humans are all sort of part of a one metrics. And so we do feature, I think, several really encouraging examples of that type of collaboration that can serve as useful lessons for others. Next slide. And one place that we try to zoom in on is the state of Michigan, which was really early impacted and found, especially within their dairy cattle herds, a really significant rise in H1N1. And so we interviewed Dr. Natasha Bagdasarian, who's the chief medical executive in the state of Michigan, and she, I think, really provides some real practical, I think, pragmatic lessons learned from their experience, especially when it comes to developing guidance and making sure that that a bit of a reality test is applied to the guidance and getting outside of the office walls and actually going to visit the places who would be most impacted by some of the guidance relative to personal protective equipment and so forth, and what's realistic for people to be able to adhere to who do want to protect themselves but are also working outside or working in the heat. What felt realistic and sustainable over time. And so I would recommend taking a look at that interview, as I think her wisdom, that she shares from that experience is applicable for other states working on H5N1 as well as, a whole host of potential threats. Next slide, please. So just kind of stepping back to think through, what are really the kind of specific implications of H5N1 and the potential for it to a greater outbreak and potentially a pandemic for older adults. As I said, CDC experts currently assess the current risk to the general population as low, but the outbreak has been continuing and in some places expanding, and so I think it's worth really taking stock of what a growing outbreak would mean for older residents. I think the first thing to understand is that there's a higher risk of severe illness. We know that older adults are consistently more likely to experience complications from influenza viruses And I think it would be reasonable to expect that to be true for H5N1 as well. Uh, we know, especially from our experience through the more acute phases of COVID-19, that there's always challenges in long-term care settings, that congregate settings like retirement communities and nursing homes and so forth really require strong infection control to protect residents and staff. Um, and and so it's always worth kind of making sure that those plans and practices are being updated and improved and adhered to, when possible, but particularly in the event of a threat like this, would want to kind of do some of that planning ahead of time. I think it's important to recognize that an outbreak like this can put a strain on caregiving systems. They can really often disrupt caregiving networks that are vital to supporting older adults' independence and well-being, particularly if caregivers become ill themselves or at least infected and are hesitant to become into contact with the person that they're helping to care for. What is the backup plan? Who can step in to assist, even temporarily? Um, I think it's worth kind of assisting in raising awareness that's something to consider and to plan for families that would apply to. I think access barriers to testing, treatment, and vaccination is always a concern, particularly for older adults who may have limited mobility, transportation, or who live in rural areas. It might be difficult to get to testing centers if testing is limited. Obviously, treatment can become difficult in the event that hospitals are becoming overwhelmed and maybe um, access starts to break down. And then particularly in the early stages of any sort of vaccination campaign, wanting to make sure that it's as easy as accessible as possible for people to become vaccinated, and that it might in some cases be necessary to go to folks who have limited mobility and want to become vaccinated, but it's not so realistic or easy maybe to travel outside of the home and to get to vaccination clinics and so forth, for example. I think in terms of uh, relative to the treatment barriers I mentioned, I think there's also greater vulnerability for disruptions in healthcare services that can happen during an outbreak that would affect the management of other chronic conditions. We saw often people were hesitant to go to the hospital or to see even their primary care physicians during COVID as people were worried about contracting COVID-19 while they were in a waiting room, for example, or just in a hospital for services that might have been quite pressing, but not quite as urgent. And so those kinds of disruptions can also exacerbate pre-existing issues. And so in terms of healthcare capacity and planning, I think always an important consideration. And then lastly on here, I wanted to kind of just highlight the importance of diverse communication strategies for all populations, but especially for older adults. Trying to think through and account for varying preferences, technological access capabilities, sensory considerations, and so forth. Just making sure that as we develop communication strategies, we're really trying to think of the needs and preferences that would apply to all sorts of populations. Next slide, please. I mentioned in the report that in addition to the indicators we track, we also include policy recommendations, and this is standard for most of our major reports at TIFA. And so I thought I would touch on a few here and then kind of dive a little deeper into some that I think are most applicable to older residents. First one, being stable funding. That's always a key recommendation for us at Trust for America's Health. We're always recommending that we try to break out of what has been a consistent underfunding, chronic underfunding of public health and a boom bust cycle where we will often neglect public health funding during in between emergencies and then surge funding during an emergency, but that is often temporary and there's kind of restrictive strings attached. And so coming out of an emergency as attention begins to divert elsewhere, so too does the funding. And that over time can hollow out public health infrastructure. And so I think having more consistent, more adequate, more predictable funding is really vitally important. Having effective leadership across agencies that focus on public health emergency preparedness and making sure that that coordination is strong is vital. I think in terms of outbreak prevention, really having enhanced immunization programs that can make sure that we're improving access and affordability is critical, as well as addressing antimicrobial resistance. In terms of community resilience, always important to focus on the social determinants of health, some of which I mentioned: housing, food security, transportation, so forth, that can really impact health, as well as community level preparedness and resilience. In terms of medical countermeasures, that is just a jargony word for accelerating vaccines and the development of vaccines and therapeutics, which can help treat illnesses related to outbreaks, and that we're always trying to improve supply chains and distribution. Healthcare readiness applies to just healthcare capacity and quality that I've been touching on. And then finally, thinking through environmental health threats, whether it's weather related, climate related. Obviously, heat is a growing concern, and particularly, I think, relevant for older residents. And so that we're strengthening capabilities to these threats and really trying to think through how do we protect residents in a changing environment. Next slide, please. And so just to kind of focus on a few that I think are most germane, we recommend sustaining and growing funding for CDC, and in particular the Public Health Emergency Preparedness Program, which supports local public health preparedness for all residents, but especially older adults. Thinking through all the planning and capabilities I've been touching on. We recommend enacting the Public Health Infrastructure Saves Lives Act, which is a law that would really help drive resources, I think, in important ways to bolstering the whole range of public health infrastructure, whether it's applies to workforce levels and staffing levels, as well as the resources and technological capabilities they need to do their jobs well. Supporting long-term public health workforce investment, which can include Public Health AmeriCorps, loan repayment for public health staff, all of whom are engaged in services that support older residents and communities. We recommend always engaging with populations and various groups to make sure that we're hearing not just their needs, but also some of the wisdom that they can offer as policies are being developed. And so engaging older residents and their caregivers directly in emergency planning, I think is always vital. And finally, addressing non-medical drivers of health, housing, transportation that I've mentioned, that can really support the resilience of communities overall, including older residents. Next slide, please. And so in terms of, these are just a few additional recommendations that I think are worth just touching on. I mentioned kind of the importance of communication strategies. I think, just reiterating that, multi-format, culturally relevant communications that are, in plain language and are sensory friendly can be really effective at reaching a range of audiences, including older adults. I think one thing that we're especially concerned about right now is protecting access to vaccines, preventive services, and chronic disease care for older adults and caregivers. And I think this speaks to, especially the chronic disease care, speaks to avoidable mortality that I was touching on earlier, making sure that our residents are as healthy as they can be between emergencies to increase resilience going into emergencies. Prioritizing heat and environmental protections for certain groups, particularly older adults as well as very young groups, and just trying to think through what are some of the particular needs of these populations and what might be barriers that they might face from some of our standard protection practices, such as oftentimes cooling centers are established, for example, to help provide a place for people to come to and to get out of the heat, and maybe if they don't have air conditioning, recognizing that it might be difficult for certain residents to be able to access those cooling centers. What is the backup plan for that? What is the plan for making sure that anyone with mobility issues, especially anyone who lives alone, that we are in touch, even at a neighborhood level with those residents, making sure that they're safe and that perhaps certain communities will even pass out fans or help install air conditioning units. Just that we're being very mindful and that that's top of mind when we're planning and going through heat waves, for example. Um, I mentioned the importance of medical countermeasures and in particular the distribution to older adults and just trying to really mitigate the effects of limited mobility and anyone who might be disabled and try to account for that. And then finally, expanding public health data systems. This has been a real area of growth, I think, coming out of the pandemic, where we really found that our data systems in many places were woefully inadequate. That health agencies were having to fax case information, from hospitals or to one another, from locals to the state level and so forth. And we've really, I think, made important strides in trying to uh, improve our data systems, not just in their technological capability, but the extent to which they will disaggregate by demographic data, so that we can really understand the particular circumstances and disparities related to certain populations, including older adults. Next slide, please. Before I close, I just wanted to kind of recognize that this is an unusual time, and in a lot of these recommendations I've been going through might seem like they are being actively undermined. And so we just wanted to touch on some of the recent federal actions that are certainly applicable to public health services generally across the country and across populations, but I think are especially relevant for older adults that really, we know that having comprehensive, robust public health services are vital for, as well as a whole range of adjacent services that can help improve social determinants overall. And so just to really quickly touch on what we've seen at the federal level in the last couple of months. We saw an abrupt clawback of more than $12 billion in public health grants that were canceled, and that this has, in some cases, halted infectious disease tracking, mental health services, addiction treatment, and other vital services across states. This was funding that was provided during the COVID-19 pandemic, but was not necessarily solely tied to COVID-related services. It was really tied to capabilities to increase preparedness and capabilities tied to infectious disease generally. And so it's really been unfortunate, and I think particularly the abrupt nature of it has really undermined state and local health departments overall. Recently, we saw 10,000 employees at the Department of Health and Human Services being laid off, with especially deep cuts at the CDC, as well as the Food and Drug Administration, which have each lost roughly 20% of their staff. This is on top of staff who left the agency after being offered payouts and so forth to essentially opt into departing their agencies. And so we're really seeing a hollowing out in terms of staffing. We have seen a significant reorganization where 28 divisions within the Department of Health and Human Services are potentially being consolidated into just 15. This would centralize authority under the secretary, as well as create a new administration for a healthy America. And I mentioned, in addition to some of these specific health services and programs, we also see proposals to significantly reduce staffing at the Department of Housing and Urban Development, as well as close agency field offices and reduce funding for programs. And so just what does this mean at a programmatic level, and how would some of these actions just affect people? I think concerned that the layoffs and the funding cuts at HHS and HUD in particular are really putting key aging and disability programs in jeopardy. Thinking about services like Meals on Wheels, which, as I'm sure all of you know, deliver meals on a daily basis to older residents who have challenges leaving their home or face food insecurity, to energy assistance programs, and to affordable senior housing support that are at risk or already being disrupted. I think older adults and people with disabilities throughout all this will face increased risk of food insecurity, homelessness, and potentially institutionalization. We've seen that many community living services are being, the staff that oftentimes would work on those programs are being cut. And so therefore, I think the capacity for delivering those services could really be reduced. And finally, state and local governments that are seeing some of their funding cut as well may be forced to fill gaps, but could potentially be doing so with inadequate resources to really kind of fully make up for some of these federal cuts. So something we're really tracking closely, as I'm sure all of you are. And I think as a whole would really undermine a lot of what I've been talking about in terms of preparedness capabilities. And honestly, I think particularly in public health, we've made great strides over the last 3 or 4 years in terms of standing up our public health infrastructure and really implementing some of the lessons learned and trying to build our level of resilience and wherewithal to detect emergencies and crises early and be able to respond effectively. And I think it would be a great tragedy to backslide on much of those achievements and progress. And so something that we're tracking closely and certainly advocating to try to apply a thoughtful approach to any of these types of actions. Next slide, please. With that, I will close up and be happy to take any questions anybody has. I've included my contact information there at the bottom. Always happy to follow up offline if folks would like.
Thank you, Matt, so much. Such a thoughtful presentation, and I'm sure it's triggered a lot of just kind of a lot of people processing all this information. I think the recommendations that you shared are particularly relevant for this group. So, Karan, can we take the slides down for now and see if anyone has a question for Matt or a comment? I know Julia had a comment, and I'm not quite sure what this is referring to, but says that disparities are among the worst in the country. So the info may be only accurate for white Minnesotans. Julia, I don't know if you would be willing to come off mute and actually ask your question of Matt or share your comment. I don't want to put you on the spot, but want to give you the opportunity.
That's fine. I was just referring to the statistic about the healthiest states, and therefore the states that are potentially the most resilient, because that's, the data is Minnesota is one of the healthiest states, and the reality is white people in Minnesota are the healthiest. So I don't really have a question. I just want to make sure that we are understanding, that everybody's understanding that that stat is not comprehensive, and it actually can be misleading.
Thanks, you Julia, for highlighting that. It's a great point. And I think, I mentioned earlier the importance of digging below some of those top line data. And so in the report, in a Ready or Not report where we introduced this data, we actually measured the disparity between races and ethnicities. And as you mentioned, Minnesota actually has one of the largest disparities that we measure there. I think it ranked 46th in the country.
Yep.
Meaning almost top five in terms of the size of that disparity. And so, while some states achieve relative success overall in terms of their overall rates, if you dig below the surface, there can still be, quite different experiences between certain populations. So I appreciate you highlighting that.
Sure, thanks.
Very good point. Other questions for Matt?
I have one, if I could.
Please, Margaret. Yes, please.
Matt, I'm Margaret Frankhauser from New Hampshire, and we're one of the states forming an age-friendly public health system. And I haven't looked at all your documents, frankly, for a number of years, but I wonder if the documents pay special attention to rural communities and the unique concerns of rurality and older adults in rural settings. Very often, emergency preparedness assumes a pretty rich and robust set of structures that may not be easily replicated in rural areas. So I wonder if it teases that out in any way.
Thank you for your question. I think the short answer is yes. We do try to, particularly with, I think, specific indicators where I think it is especially impactful, thinking about flu vaccination, for example, where it's important to address, potential transportation challenges, but also we find that often local public health departments that are rural can be under-resourced, that services might be less comprehensive, and so we try to kind of lift that up in our reports when possible, and really try to, as we speak about the importance of equity and public and health equity generally, I think we, as a practice, always trying to recognize that urban-rural disparities, I think, are an important dimension of equity, but can sometimes be overlooked or not sufficiently recognized. And so appreciate that for you mentioning that. And I think we do try to touch on that and have specific recommendations that speak to how some of those disparities can be mitigated. Or alternatively, trying to lift up particular needs or areas where greater planning is necessary, but can certainly always do a better job of that. So I appreciate that comment.
Thank you, Margaret. Thank you, Matt. Other questions? Matt, I'm wondering if folks, in the lower or even the middle tier of states, are looking at those tiers and thinking, they want to be in that higher tier. They want their states to be better prepared. Where do they start? Like what should they be doing to improve their status?
Yeah, it's a great question. I think one answer is it sort of always depends, for states. But I think, in terms of, and we do include indicator-specific data for every state to try to give a snapshot for folks in the report to understand how they fared within these indicators and how that compares to other places. In terms of specific areas to look at, I think whether or not a state has joined the Nurse Licensure Compact, that is one that is, I think, quite actionable for policymakers in a state to pursue. And I think that there's a lot of evidence in the last, in recent years showing that can be quite beneficial. I think pursuing accreditation, either from the Public Health Accreditation Board or the Emergency Management Accreditation Program, we track both in the report, can be quite beneficial. We do recognize that in some cases that the costs associated with pursuing that accreditation might be prohibitive in some places. And, I think sometimes there are sort of strategic decisions to essentially adhere to a lot of those standards and practices, even without actually achieving accreditation. We do recognize that, and I think speak to that in the report. But that is, that is a place to look for, just to kind of stress test, I think, the capabilities overall, and make sure that current practices are meeting kind of professional and high quality standard benchmarks. Public health funding is something we track every year, and whether or not states are making sure to not cut their own public health funding from their own revenue, that they have purview over. We specifically try to isolate out federal pass-through funding, so we're really trying to zoom in specifically on the funding that states control most directly. Certainly trying to regularly increase public health funding, particularly to catch up after potentially years of cuts, but also to prevent any type of backsliding. That can really help to increase local infrastructure overall, which can have numerous benefits, that really cut across, I think, the continuum of public health services. And so those are some of the areas I would probably focus on for being especially impactful, but also highly actionable by policymakers and others.
Great, thanks, Matt. Claudia, you have your hand raised, your virtual hand.
Yes. Hello, I'm Claudia Alamine, and I'm here in Oregon. And I did note that Oregon was in the lower tier. And I'm wondering if part of what you track is looking at the urban areas versus the rural areas, because there has been a push to try to get more resources out to the rural areas, because there's some areas in our state that are very, very low resource. We'll just put it like that. Very low resources in some of the counties, and also just don't have a lot of access, or have very little access to even say hospitals. And having lived in the rural upstate New York for many, many years, and coming from New York City, born and raised, and living up there on a farm, and then I'm sensitive to rural communities and how they survive, used to survive through networking, with neighbors and stuff. I'm not so sure that happens anymore, without some sort of centralized community effort. I mean, anyway, that's my question.
Thank you, Claudia. I appreciate it.
It's a great question. And I think, as I touched on a bit earlier, I think that while we don't disaggregate our indicators necessarily in that way to kind of focus in that sense, we do, I think, throughout our discussion and our analysis of the indicators, as well as our policy recommendations, I think we try to continuously reiterate the importance of identifying inequities and disparities across several dimensions, including unique risks, but also barriers, access challenges, et cetera, that would apply to rural residents. Try to make sure that some of our recommendations help to suggest ways to mitigate those. But also, I think a consistent theme is in any sort of planning and preparedness work that's being done, it's always important to hear directly from populations that would be impacted by emergencies, but also by these plans. And so, what we're always recommending is to, engage in genuine community dialogue to learn from and benefit from the wisdom of those types of populations, so that we try to cover up for blind spots that might otherwise be there. And I think this is a great example of that, so that residents or representatives representing rural areas can really try to make sure that the people who are engaged in this kind of planning are thinking through all the kind of location-specific challenges that might exist, and that we're planning ahead to make sure that as much of that can be addressed and mitigated as possible. And so that's a consistent theme in this report as well as other TIFA reports.
All right, thank you so much, Matt. We are at the end, just even a minute over the end of our time, but great conversation, really good questions, very important content. Thanks so much to all of you for attending. Please don't forget to answer that survey for us and to join us next month, where we will be exploring opportunities to really enhance collaboration all across the age-friendly ecosystem. So Matt, thank you once again. We're going to officially adopt you as part of our policy development team, I think, in the future. So stay tuned for that. So thank you, everyone. Appreciate you joining us.